Okay, we will start now. Hello everyone, I am Mustafa Shalabi. I am the director of the CME program at Mansoura University. We are delighted to start this webinar today, which is hosted by Mansoura University with an expert panel from Kentucky University. Unfortunately, this is a hard and busy time while we standing in the front line in this COVID pandemic. Now I will introduce Dr. Amr Elhusseini, professor at the Division of Nephrology at Kentucky University. Also, he has a professorship appointment at Nephrology Unit, Department of Internal Medicine, Mansoura University. Dr. Amr will share this webinar. Dr. Amr, could you say hello?
Thank you so much, Dr. Mustafa. Thank you, Dr. Nasreen, for giving us this opportunity and for coordinating and arranging this webinar. It's a very hot topic, as Mustafa said, and all of us are in the same boat. I mean, if anybody told us about this a couple of months ago, we wouldn't even believe him. Now, as a healthcare providers, we need to steadfast and get united to see what we can do to improve our patient health, to stop spreading the disease, and to win the battle. I have a very distinguished speaker today. I have Dr. Fabrizio Canepa, who's going to talk about global epidemiology and hospital protocols. I have Dr. Neyra. He is a critical care nephrologist, and he's going to talk about ICU policies and how to deal with critically ill patients in the ICU. I have Dr. Mike Winkler, who is a cardiac radiologist, is going to talk briefly about the CT findings in patients with COVID-19. Then he is going to talk about an interesting topic, which is emergency printing of medical supplies. So I think he will help us locally to print our supplies that we have shortage in. First of all, just very important notes that all the information we are discussing today have to be mentioned under the circumstances that whatever we know about the COVID-19 is much less than whatever we ignore. And also all the information data we have is limited to the time. So it's 27th of March 2020, because time is essence here and the information is changing minute by minute. We are going to stick to the official information that we have for the pandemic, but you know that there is very few, if any, evidence-based medicine for the COVID-19. No one can win this battle by himself. We need to work together as healthcare professionals, not only the physician, but also the nurses, the techs, and all staff. We need to work to be organized. We should have team leader and we should have team players. We need to work together. Everyone should know which one is doing what. We need intelligent strategies, and we should have dynamic procedures and policies, because the policies can change from time to time and from a place to place. So it has to be flexible and adjustable, and we can accommodate for the time and place. This battle is not one nation battle. It's not one race battle. It's not religious thing. It's things that's going to affect all of us, not only at the healthcare level, but also at the social and economic levels as well. As people, as human, we are living in the same globe. We are living under the same earth and on this under the same sun and on the same earth. So we have to get united and we have to work together to defeat this virus. Our goal is not only to provide good care and save lives, but also to protect ourselves and our family and our staff. Our strategy is either going to protect the spread of infection and save our lives, and if we fail this battle, and there will be a lot of losses, not only to our community and our nations, but also we are going to lose our loved one and our friends and colleagues. It's a major challenge for all of healthcare systems. Now, I think we need to focus on building up our infrastructure, focus on relocating our resources, focus more on our patients, our healthcare systems and resources more than any other time. The resources is very important in this battle. And it's very important to say that this COVID-19 is a source of major anxiety to all healthcare providers. We received with sadness and grief the news that one of the healthcare nurses in Italy committed suicide a couple of days ago because she thought that she might be a reason for the spread of the virus. Yesterday, Iran just said there is 43 doctors and nurses died because of fighting the virus. So it's very important to support each other and to step fast together to defeat this virus. It's a war, and this war is with unseen enemy. Right now, we are trying to hide, to escape, to run away from the virus, but hopefully in the near future, we can start to attack the virus with approved medication and, of course, with the vaccination. The healthcare workers now are in the front line of this battle. This is not a soldier battle, but it's a healthcare professional battle. So we need to work together to defeat this virus. One important thing I need to mention is we have to stick to our official and authentic resources. There is a lot of information in the media, but as healthcare provider, we need to focus on our local authority and also our national and international organization. We focus mainly on getting information from the WHO website, from the CDC website. And locally, I think every healthcare system should have its own local policies and procedure. As you see here, we have built a website specific for the COVID-19. So you can search this covid-19.ukhc.org. And as you see here, this is our local healthcare website. And this site is updated minute to minute, give us all information about what's going on in our hospital and in our community. As the last night, we have tested in our hospital 1,257 cases, and among from these cases, we have 1,222 negative patients, and we have 35 positive patients. Among these 35, 3 was in the hospital, 1 recovered and she's back home now, and 2 is still in the hospital. The rest of the 32 patients are outpatients. So as of now, apart from more than 1,000 specimens we collected and tested, only we have 35 positive patients. Then this website has a lot of resources that it's not only helpful to us at University of Kentucky, but also can be helpful to anybody. As you see here, this is the news that we are building our telehealth system. So we are moving all of our clinics, outpatients activities to remote telehealth. Now we have a drive-through testing for UK employee to get tested for any suspect with coronavirus, can stop by and get tested without going to a lab and getting in touch and face-to-face with other people. Also, you can see there is a lot of guidelines at the clinical background. There is a lot of information for the ambulatory, for the clinic, for the contact and airborne protection, and also handouts for the patients with different language, even with the Arabic language. So there is a lot of resources that we can use. We are also following the Johns Hopkins website about the dashboard for the spread of the virus. As we know, for now, we have more than 566,000 patients infected with the virus. In America, we have more than 92,000, very close to 93,000. The mortality in America, we have 1,438 mortalities. As you know, and I'm very sure that you're following that too, if you see Egypt has 495 cases confirmed with the COVID-19 and 24 mortalities. I think I will stop by here as this is very enough for the introduction, and I'm going to introduce our first speaker today, Dr. Fabrizio Canepa. Dr. Fabrizio, he joined us at University of Kentucky 3 years ago. He has 9-year experience as hospitalist. He was graduated from Henry Ford University, and he is one of the members of our COVID-19 task force at University of Kentucky. Dr. Fabrizio.
Thank you for the introduction. Thank you very much for having me tonight. I'm going to go a little bit about epidemiology. As it has been said before, this is ongoing changing. The data changes every single day, and there is multiple studies day by day. So a little bit about the virus itself. It's an RNA virus, very similar to the coronavirus type 1 that caused the SARS pandemic or brought in China in 2002 in the east of Asia. The most important part of the virus is the S protein. That is the one that requires for cellular entry, and it binds to the ACE2 receptor in the lungs. Then there's endocytosis, and there's the RNA gets duplicated by the host cell. This is a little bit of comparison of the SARS virus, the MERS, the flu. As you can see, the COVID-19 disease has an R0 between 2 or 3, probably a little bit higher. The case fatality rate is 3.4, although it varies, and we're going to talk about this later. The incubation time is between 4 to 14 days, and the hospitalization rate is 20%. So talking about how it affects different countries, In China, the case fatality was around 2%, and in Italy, and this is probably old already, it's 7.2, but taking the data from today is up to 10%. Many theories about why the difference. It could be certainly because Italians have an elderly population. However, the distribution by age and the fatality by age remains similar between the two groups, with the increased risk of death amongst those more than 60 years old. Very interesting, South Korea has a completely different epidemiology, with a big amount of cases amongst those young and probably symptomatic. South Korea had a complete different strategy in regards of public health when this started, and their strategy has been extensive testing, and testing even those asymptomatic. So as you can see here, Italians are testing only those symptomatic or those who present to the hospital, and South Korea to almost everyone. And you can see that the percentage of those younger in South Korea is up to 30%. And this is a timeline of cases. You can see that the cases have doubled, and especially in March, every 3 days, there's 100,000 cases new, and probably it's gonna get worse if we don't try to do some mitigation. And this is a nice graph that you can compare how the cases have gone. This is the confirmed cases since the 100th cases. In both South Korea, Japan, Singapore, when they have done either strict quarantine or extensive testing and surveillance of those positives and their contacts, the curve has flattened. In countries where they have tried to do this later, like Italy or Spain, the curve is much more deep, and the US, unfortunately, has grown up because probably a delay in these public health measures. Kind of the same as fatality, with Italy probably in the peak because of that large elderly population, but Spain getting very close. So as we were saying, the epidemiology, the incubation period can be between 1 to 14 days, the median is 5.1. There's reports as long as 24, and sometimes I think there was one up to 30 days. The R0 is between 2 to 3, and the case fatality rate varies across countries. South Korea is 1.3, Italy is up to 10%, and I think it depends on the denominator, how many we're testing, and the demographics, the density. There is certainly evidence of asymptomatic transmission. Very interesting for me is the Diamond Princess. There was this cruise that was in the coast of Japan. They tested every single one, and we had a very big amount of asymptomatics. They were up to almost half of them were asymptomatic. And the fatality rate in the ship was 1.3, very similar to the South Korea figures. So I think that the spectrum of disease goes from asymptomatic to mildly symptomatic, symptomatic enough that needs hospital admission, and those severe that develop ARDS. The clinical presentations, as you all were aware, fever probably is one of the most common symptoms, although many of the newcomers don't have fever on presentation to the hospital. Cough is the second most frequent symptom. You can have myalgias, fatigue, sore throat. There's a big discussion about how prevalent is the GI symptoms. Headache and rhinorrhea is really, really rare. A couple of symptoms that have become a little more aware lately is anosmia, so lack of smell and lack of taste, and also bilateral conjunctivitis. The laboratory findings, the normal CT can be up to 86%, and probably we're going to talk about that later. Lymphopenia is probably one of the most frequent abnormalities encountered. There's mild thrombocytopenia, although it's never severe thrombocytopenia. CRP is usually very high. Procalcitonin, unless there's a co-infection, is not very high either. there's mild transaminitis, and the D-dimer is usually elevated in almost half of the cases. I really like this figure. It kind of tells you that there's different phases of this disease. Probably there's an early phase where there's the viremia, that there's non-specific symptoms. Probably the elderly and those with comorbidities are affected in this early phase. And there's kind of a later phase in the disease where there's a pro-inflammatory response kind of after 5 to 10 days. So many patients are doing well in the first days of disease, and then when the inflammatory system, the adaptive response kicks in, there is this ARDS picture. The risk factors, of course, all of those with comorbidities, hypertension as high as 90% according to the data of Italy, basically every coexistent disease, older age, and there has been some association with males who have a higher disease. The labs where there's worsening prognosis, D-dimer, high CRP, high LDH, high ferritin, and elevated troponins. A little bit about diagnosis. What we're doing here, and I think most of the world right now, is the nasopharyngeal swab. However, you know, how positive the result comes is about 60 to 70%. In the bronchoalveolar lavage, probably is a little bit higher, but with the risk of aerosolization, so it's not recommended. So we have to be conscious that the test is not perfect. However, already in South Korea, and I think that we're starting to use it in some parts of the United States, we're having some serology testing. So as you can see, the PCR positive is only in 75%, but when you combine it with the IgM plus ELISA, the PCR with the IgM, it can go up to 98.6. So probably this is gonna be helping us in those with PCR negative. Now a little bit about hospital protocols. Really, we have to prepare and plan for the worst. Depending on the area, we have to anticipate to a 200 or even more surge in the census. At this point, for example, here we have stopped elective surgeries. Most outpatient visits are done through telemedicine. We have created here at the University of Kentucky for those non-ICU patients, we have created a backup contingency plan. We have a list of 3 extra doctors signing just to be ready for that surge in cases. In case the hospital of medicine were running low, we already have contacted all those outpatient doctors and the family doctors. So we need to have a really contingency plans for not only the surge of cases, but also many of us are either going to become sick or we're going to be in isolation for positive contacts. I think at some point we have to create COVID-19 units where the cases, the healthcare workers work exclusively there. And the benefits of this is that there's decreased use of personal protective equipment. The personnel get more experience with the patients. And the way that they have been done in other countries is shorter shifts to decrease exposure. We were talking about we as healthcare workers, we're going to be at the front line. Unfortunately, the data says between 20 to 30% of healthcare workers were going to become positive. And of those, unfortunately, there's 60% of in-hospital transmission is because of healthcare workers. A way to minimize exposure is decreased frequency of encounters. For nurses to the medication, instead of being 2 or 3 times a day, try to make it once a day. Think about telemedicine, talk to the patient over the phone. We have to use a wise use of our resources, the personal protective equipment. I think it's very important involving ethics in all the protocols for the pandemic, for allocation of resources. And a big problem that we're anticipating here is that these patients that go through an ICU, because the average hospital stay is 2 to 3 weeks in order to recover, and then they're going to have needs as potential rehab, but those facilities are not accepting those. So we have to have a close coordination and maybe a strategy is swabbing this patient at discharge because we don't want to spread it in nursing homes. This is some of the protocols that we wanted to share with you guys. This is, for example, for admission, a patient presents to the ER. If they have the classic symptoms, the patient gets a mask. The patient is putting droplet precautions. They get a viral respiratory panel, including influenza, because it's still this high season here. The patients are also tested for COVID-19. If they become positive, the precautions are changed to airborne with eye precautions. Very important to mention that there's some studies that they have seen co-infection with other viruses up to 20%, especially with rhinovirus. So you see rhinovirus, I still look for COVID-19 if the clinical situation is very suspicious. There can also be bacterial co-infections up to 10%. So in those patients with a high procalcitonin, or they have a later decline, we have to suspect on those. Although the best strategy is wide testing, the wide testing doesn't become available immediately. So for example, here we're not testing every single patient. If the patient does not require hospitalization, cannot hit the first to clinical judgment. If they have the classic symptoms and they are population, either healthcare workers or patients with comorbidities, the testing is recommended. If they have the symptoms and are any close contact with within the last 14 days with a COVID-19 positive, the testing is recommended. And of course, everyone that requires a hospital admission, testing is recommended. I think eventually, as countries are getting prepared, we need to do as much testing as possible, but this is a strategy while that testing is not widely available.
Okay, very good. Thank you so much, Fabrizio, for this terrific information. I think the next step is we have a case of COVID-19 healthcare worker who is just recovered from the infection and would like to share with us his experience. So let us see if we can get him connected, and so he can share with us his experience with fighting against COVID-19. Maybe Dr. Mustafa can mute Dr. Suleiman. Can you unmute him?
Dr.
Bilal, can you unmute Bilal?
Okay.
Yeah. I think we can hear you now. I think he has problem connecting.
Maybe.
We can hear you. Do you want to share with us your experience? Yes. He is here over the phone. Yes, please.
Okay, so again, I'm not sure how much of my initial introduction you heard, but basically, my name is Bindad Suleiman. I'm an internal medicine resident at the University of Texas Southwestern. Here you see my patient information. I'm a 33-year-old male, no real significant past medical or surgical history, no social history of note either. And again, I'm an internal medicine resident here in Dallas, Texas. And I would with my personal experience with dealing with the novel coronavirus. And so just in general, my initial day of exposure, I call day 0 here, was on the 17th of March. I was exposed to, I later found out to be a positive patient who had just returned from New York City 3 to 4 days prior to my exposure to them. That day, the patient had any symptoms at that time, but that evening developed a fever and subsequently tested positive the next day for the novel coronavirus. The day after I was exposed, I had no symptoms. I was unaware of my exposure at that time. The second day, on the 19th of March, I noticed a little bit of fatigue, maybe a little bit of difficulty of concentration, a mild sore throat. I thought I could have, just an amount of fatigue from working a week of nights, so did not think much of it. I thought maybe my sore throat was possibly due to some allergies or seasonal change here in Dallas at the time. I fortunately did not come into contact with any other patients day 2 and further along. That evening, hoping I would wake up feeling much better. Unfortunately, my symptoms were much worse in the morning. I woke up with a fever to 100.4. I had a severe unilateral headache. Didn't appreciate any phonophobia or photophobia at that time. Really severe arthralgias and myalgias. Was basically stuck in my bed for most of the day that day. I had pretty prominent malaise. My sore throat was mild all along, but I did have pretty mild to moderate, I would say, GI symptoms. I had intermittent nausea. Since my initial day of symptoms, my sense of smell and taste have completely gone until today. Never really developed any severe respiratory symptoms. I had a mild non-productive cough, but my fever did increased that day despite having around-the-clock Tylenol or acetaminophen, which I was taking every 6 hours. The following day, I spoke with my hospital administration, and they they told me about the positive exposure that I had, and that I should be tested. I tested through a drive-through testing center that we have here at our hospital, and within 3 to 4 hours, I was called with a positive result, and that was on day 3, the 20th of March. I was directed to stay home and to self-quarantine. I was told to take Tylenol and to avoid any NSAIDs, which I did. The next following day, I was persistently febrile to as high as 102.7, despite the around-the-clock Tylenol that I was taking. I developed some chills and rigors, and then was also having some exertional sort of dizziness and persistent nausea. Day 5, I was only febrile one time in the evening to 100.4 low grade, but my symptoms continued to persist, although slowly improving. Day 6, not much changed, although it was my first febrile day. And still dealing with some mild symptoms. On day 7, interestingly, I remained febrile, but did develop new upper respiratory infection symptoms with rhinorrhea, sinus congestion, and I would say my sense of smell and taste probably completely diminished at that time. And then day 8, I would say most prominent were my sort of minimal sense of taste or smell at that time. The day after that was yesterday, which was initially was planned to be my last day of self-quarantine, and I was planning to go to work today. In that the sort of institutional program, the institutional decision makers had decided that 7 days after first onset of symptoms or fever and no fever for 72 hours, that I would be able to return to work. And I think that's very much in flux at the moment. So many different policies have been kind of gone back and forth at this moment. It seems like that's the prominent one that we're following. In speaking with infection prevention and occupational health, I was told that I needed to wear a surgical mask until day 14 after my initial symptoms. So notable things that they thought I would point out: I did not ever develop any shortness of breath. My cough was only mild and non-productive. My GI symptoms were pretty, I would say moderate, and I still continue to deal with some of them. Nausea, occasionally anorexia. I still have to some degree, but never developed any diarrhea, which I've seen reported in some studies out there. And these are the instructions that I kind of discussed and was told to follow after I was given a positive test. And that was my experience with the novel coronavirus. At the moment, I feel much better than my initial day or days of symptoms, where I had lots of myalgias, arthralgias, and malaise. But fortunately, it seems like I've, for the most part, recovered.
Very good. I really appreciate your help and your contribution to this meeting. Please stay safe and healthy.
Thank you. Have a nice day.
You too. I think the next speaker will be Dr. Javier Neyra. Javier is one of my smartest colleagues that I have ever worked with. He is an ICU nephrologist. He is a physician scientist, and he is very well published, very well known in the area of critical care nephrology. He mentored a lot of mentees and trainees since he joined us 5 years ago. And he is going to talk today about some of the ICU policies and also about some of management of critically ill patients with COVID-19.
Yeah. Okay, thank you very much. That was a very kind introduction. If you allow me to share my screen, I will share my slides.
I think you could share your screen.
Okay, so let me. I think somebody needs to stop sharing still, so I can do it.
Could you, Dr. Amr? Yeah. Could you, Dr. Amr, stop sharing? Yes.
We already stopped sharing, so I think you can.
Excellent.
Share your screen.
Okay. So in this next few minutes, I'm gonna talk a little bit about COVID-19 and AKI. Initially, we're gonna discuss just one slide on preclinical observations. Then we're gonna talk about clinical data and a little bit on the RRT protocols. The preclinical studies show that ACE2 is a viral receptor for COVID-19, and this is a mechanism for the virus to go into the cell. Therefore, ACE2 is highly expressed in the proximal tubule and becomes a concern in regards to kidney injury. The kidney pathology that was reviewed in 6 autopsies in China revealed severe acute tubular necrosis and leukocyte infiltration. Importantly, the antigen was accumulated in kidney tubules. So we know, and there is this picture depicting this, that the proximal tubule has a significant concentration of ACE2 expression, and therefore becomes a target for potential therapies. That's the only slide I have about preclinical studies. As you know, this is something novel and is all under investigation. But we can review a little bit of the clinical data and the experience we have from other countries thus far. This is just a nice diagram. I think is relevant when we discuss about AKI, because in these stages of infection, we have the earliest stage, as you can see here, where there is the viral response phase. Typically, the symptoms that Dr. Canepa mentioned initially, the mild constitutional symptoms, fever, dry cough, diarrhea, headache, and we had this presentation of somebody that was positive for the virus. Typically, it's in this viral response phase. If you do some lab tests, you can have this lymphopenia, increased prothrombin time, D-dimer, and LDH. This increased D-dimer has been a clinical characteristic in the lab test that has been reported by many people in the US as well in exchange of communication. So this is something to keep in mind when we evaluate these patients. And then we go into the stage 2, the pulmonary phase. Of course, there is this phase, the viral replication is decreased, but there is definitely some lung injury. Some of these patients will start to manifest with shortness of breath, hypoxia, and they can have already abnormal radiographic findings. And importantly, in the third stage, it's a stage of hyperinflammation where we have this host inflammatory response phase that can manifest with multi-organ failure. These are the patients we will see in the ICU with ARDS, shock, cardiac failure. There has been reported a lot of myopericardia, infiltrates, so pericarditis, myocarditis are common findings that we're seeing in these patients. And of course, if you measure inflammatory markers, they will be elevated: IL-6, LDH, CRP, troponins, particularly in those cases with myocarditis, and NT-proBNP as well. So in this stage 3 phase, hyperinflammation is where we have risk of acute kidney injury. And importantly, some of these patients will require renal replacement therapy for the management not only of the AKI, but of the multi-organ failure and the fluid overload that is very common in these patients. In terms of therapies, of course, there's a lot under investigation. There are clinical trials ongoing for remdesivir. Some centers are using chloroquine or hydroxychloroquine as part of their protocol. The convalescent plasma transfusions also under investigation, and steroids that could palliate a little bit this phase of inflammation. Some centers will use steroids in individual-based evaluation, not protocol-based, because still the data is not very solid. And of course, we have other medications to be considered and under investigation. In terms of incidence of AKI, we learned from China mostly this data coming from, there is a study here in this table. This was compiled by the Neph Journal Club group very nicely. This study here in JAMA is from Seattle, but most of the other data come from Wuhan in China. So you can see the risk of AKI is very variable. So it has been reported from 0.5% up to 23%, 19%. Keep in mind that at least in this study in Seattle, all of these patients were in the ICU, critically ill. So this incidence definitely will be affected by the clinical status of the patient and if the patient is in the ICU or not, but very variable incidence. So in general terms, when we are looking for preparedness, that is what we are now trying to develop, especially in places where we don't have that many cases yet. It's a good estimate to have between 10 and 25% of your cases will require potentially some support with renal replacement therapy due to AKI or multi-organ failure. So just for you, when you start analyzing capacity on your centers, it's a good estimate to consider. As you can see, need for CRRT, very variable, up to 10% in some centers, and in some as low as 0.8%. Importantly to notice is that patients that develop AKI, in most of the studies, they report a lot of comorbidity. Importantly, diabetes, hypertension, most commonly, and some degree of chronic kidney disease as well, present as risk factors for or clinical parameters associated with AKI. In terms of outcomes, we know epidemiologically that AKI increases risk of mortality and morbidity in critically ill patients. This is the same for patients with COVID-19 infection. As you can see, when in these studies, they analyzed patients that died. The incidence of AKI in patients that died was variable from 4% up to 23% in some of the reports. Patients that require RRT, like in this study in Lancet, the 10 patients that require CRRT all died. And that is related to most of the time these patients have multi-organ failure, and the mortality that already is 50 to 70% in a standard critically ill population may be higher in these patients, in which apparently the phenotype of acute disease is very sudden, and sometimes we don't have much intervention in a timely manner to prevent their outcome. But yeah, so that's something to keep in mind when we address the risk of morbidity and mortality in these patients. So AKI in the context of COVID-19 critical illness should be considered a risk factor for adverse outcome. A couple of comments on drugs, especially if you are in centers that are doing clinical trials with remdesivir, or like using other antiviral or other drugs. There is no adjustments in patients with AKI or patients that are receiving renal replacement therapy, except for remdesivir, that potentially clear with CRRT. Of course, this has not been studied, but there is a potential clearance that is highlighted because of the molecular size of the drug. Interestingly, in the studies, at least in the US that I'm aware of, that are enrolling patients for this trial, they are typically excluding patients with baseline GFR or creatinine clearance less than 30 or less than 15 in some studies. So patients with acute or chronic deterioration in kidney function are not considered. So therefore, this is not a consideration in the ongoing trials, but it can be raised as a question in the future for patients that are requiring RRT. The other drug, favipiravir, it's also could potentially be clear, but this is less commonly being used as of now, and I'm not aware of any trial actively enrolling for this, but there may be some. And in the last couple of minutes, I'm going to mention some general comments about the provision of RRT that should be considered. This depends on the center, but nephrologists, intensivists need to work together along with the dialysis and ICU staff in terms of having adequate PPE for the provision of RRT. It's recommended that patients that are positive, all the PPE precautions are considered. Sometimes the concerns are patients under investigation, and especially when there is not much access to PPE equipment. So in those cases, you try to generate less contact with the patient as possible between the staff and the provision of RRT for the patient. So the preferred modality, especially in patients in the ICU, is CRRT. As I said, and we were discussing this earlier today, those patients with mild AKI or patients with AKI that are not hemodynamically unstable without other organ dysfunction are not very common. Typically, you will see patients either without AKI or with AKI along with multi-organ failure, fluid overload. So therefore, most of the time, a patient will be requiring CRRT. In centers that don't have CRRT, more intermittent modalities like PIRT or SLED should be considered. Of course, you need to understand your capacity to be able to provide CRRT in these scenarios. And also the capacity is not only talking about the logistics, having machines, but also the personnel that is trained to deliver the treatment at the bedside. In cases in where there is ICUs, where the ICU nurses are trained to provide CRRT, that's the ideal scenario, but in institutions that hemodialysis nurses are the ones that setting up the machines, you should try to avoid too much contact with the patient. Some strategies are to prime the machine outside the patient room. And even in some institutions, they are evaluating the feasibility and safety of keeping the dialysis outside the room with longer tubes. But I'm gonna have a comment about that is of concern in my last slide if that's something you guys are considering. Also, you need to follow your institution policies in general regarding the protocol of RRT. It's better, and we recommend not to be too innovative because in regards of trying to provide new protocols on the go, because that would be more susceptible to error. Stick to the protocols you have, but with the caveat that you need to try to minimize exposure from your staff, clinicians, nurses, with the patients that are positive. The filters on CRRT should last around 72 hours. So it's recommended to use regional anticoagulation for these machines. There is a lot of reports that there is a lot of clotting, and that definitely can be of consideration, especially because this will require more troubleshooting of the machine, more nurse exposure to the patient room, especially if the machine is inside the room. And then the disinfection of the equipment, it can follow your standard institutional policies, but you need to be sure that the disinfectant material you're using is EPA list N. And there is a link here that we're happy to share where you can see how you disinfect these devices. Typically, we use wipes for the external surfaces of the machines. Need to be listed that are effective against coronavirus. And there's a link from the CDC. You can review the material you are using for disinfection and be sure it's adherent to the policy. And of course, when you provide CRRT, all the disposable equipment of the machine, the tubing, the filter sets should be discarded according to the hospital infection and control policy. In our case, this is just to emphasize, this is recommended you generate some workflow for your program. And in this context, you kind of differentiate patients that are in a setting of a sequestered ICU unit. Those are patients that all the unit is locked and reserved only for positive confirmed cases. In those scenarios, the devices will stay in those units, and you have less contact with that devices from other personnel. So in the cases you are not having a sequestered ICU unit, you need to be very careful that the machine is disinfected inside the patient room and then can be transported to the place you store the machines, and that the team that is in charge of transporting the machines or managing the machines, it's aware of all these disinfection process guidelines. Other considerations, and this is my last slide, is the capacity. So even if you have a CRRT program and you are not prepared to expand your capacity more than 50%, you should consider intermittent modalities with your own devices. So your own CRRT machine can be used for 12 hours, 10 hours in a modality of PERT or a SLED. And in that context, you really can maximize the availability of your machines. Also, you can use your hemodialysis machines to provide intermittent renal replacement therapy in a modality similar to a SLED. For example, in our institution, one of our strategies will be, if we maximize our capacity, we will do these SLED treatments in the middle of the night from 7 p.m. to 7 a.m. with the dialysis nurse on call, monitoring these treatments in the ICU. That will liberate a lot of our CRRT machines for other patients, and also our HD machines will be able to assist the SLED treatments in the middle of the night. The other thing is minimizing nurse exposure by distancing the machine from the patient. You need to be careful with this longer tubing for CRRT outside the room, because some devices are not prepared for this longer tubing. And there are two considerations: that some of the alarms may be triggered, and this will generate more troubleshooting. And the other one is that you have an additional 150 mLs of blood in the extra tubing for both ports, the arterial and the venous port. And of course, in a patient critically ill, in shock, that may be a significant amount of blood loss to be considered. In our institution, we decided not to extend the tubing to have the machine outside the room, but I'm aware of other institutions doing it and doing it successfully. So this is, you need to evaluate at your corresponding institutions and decide if that accommodates better your needs or not. The other thing to consider if we maximize capacity is the use of AV fistulas, AV grafts for the provision of CRRT. There is a report from University of Michigan, Michael Heun, that provided his experience a few years ago. This was safe for them, but they required the dialysis, the hemodialysis nurse to access the fistula first, and the ICU nurse will monitor the treatment on CRRT as they usually do. But any consideration, of course, is the risk of bleeding if the needles are dislodged. So this is not recommended unless you have really a bedside team that can monitor very carefully those needles and the treatment. But those are last resources in case of maximizing capacity, are not having staff available to place temporary dialysis catheters. And finally, one comment on hemoperfusion, hemoabsorption. We don't do it routinely in the US, but especially in Europe, there are centers that have done hemoabsorption. Hemoabsorption basically will try to diminish this pro-inflammatory response, this hyperinflammation in the patient through removal of some middle-sized molecules like cytokines. However, these modalities have never been able to be highly correlated with outcome in different studies, certainly have not been studied in COVID-19 scenarios, but they conceptually make sense. If you have this technology available, yes, you can try it, but trying to incorporate these technologies on the go may be challenging if you don't have your team trained for this. It can be connected in tandem to the CRRT machine and through the ECMO machine, depending on the patient status and what extracorporeal support they are receiving at the time. Just in terms of protocols, this is a nice summary slide from Mass General protocol. Typically, the recommendation in critical ill patients is lung protective ventilation. As you know, try to have a tidal volume between 4-6 mLs kJ, plateau pressures less than 30, driving pressures less than 15 millimeters of mercury, and a PEEP starting around 8 to 10. And finally, having a conservative fluid strategy, a PEEP titration protocol. These patients respond very well to pronation, so that's a consideration to be established as well. And also additional therapies like paralytics or inhaled nitric oxide could be important. ECMO in patients that are refractory to the respiratory support to the mechanical ventilation, and CRRT for fluid management, definitely considerations in these protocols. As you can see here, for the therapeutics in Mass General, they do have this line of considering hydroxychloroquine and statins, and they are also part of the remdesivir clinical trial. Okay, so with that, I just want to finish my part of the presentation. This was just a brief overview of critical illness, AKI, in these patients.
Very nice. I really thank you for this excellent presentation. Please stay with us because we will need you to answer questions. If you can stop sharing. So Mike Winkler is the last speaker, then we can take some questions. Mike Winkler is a professor of cardiac radiology, and also he has an appointment in the School of Art because he has a very good experience with 3D printing, So he is leaving us, at University of Kentucky, and he is joining the University of Georgia at Augusta. I think he will have more role there for administration and better opportunity for research. So I hope the best for him. We will miss him here at University of Kentucky, but we'll be in touch. He's going to talk today about an interesting topic, which is how to print medical supplies if you have shortage in masks and other equipment, how he can help us to locally print those. And he can also give some data about the CT findings of the chest and heart in patient with COVID-19. Mike.
Thank you for that introduction. Can you all see my screen?
Yes, I do.
Thank you, Amr. I'm going to briefly touch on the radiographic findings for COVID-19, and then we'll move rapidly into a discussion of fabrication. So hopefully you all can now see our YouTube channel, SAVS Volumetric Visualization Laboratory. Amr, can you confirm that that's?
Yes, we do.
Okay. So we do a lot with this channel, but we have a playlist for COVID. Perhaps we should start with radiographs. So this is the initial conventional radiographic presentation of a confirmed patient with COVID. It's non-specific. What you will see are patchy airspace opacities. Now, this is a young and healthy individual. For renal insufficiency patients, you will see edema and effusions as well because of issues with volume. Much of the literature says that there are no effusions. Now, I'm going to pause here. Much of the literature says there are no effusions with COVID-19. That is not true. What we are seeing is that in Kentucky, where we have a very sick population with comorbidities, our findings are different than those findings that the initial meta-analyses that are coming out of China show. Those patients are so much healthier because of a healthier lifestyle. So in Kentucky, at least, we are getting COVID plus other things now. And this is especially problematic. Amr, I spoke to a hospitalist yesterday in a renal transplant patient. I called him up and said, this patient likely has the COVID-19 pneumonia. And he said, no, their shortness of breath is due to volume overload. And there is this lag time before people realize that their regular patients who are already sick are going to have this super infection. Okay, let's go on. So then very rapidly it deteriorated and the patient required intubation. So the patches of airspace opacity are a bit worse here, but there's also a lag, or the patient is more severe clinically before you get into a full-blown adult respiratory distress syndrome-like picture. Let's move now to CT. This is a different but also a confirmed case of COVID-19 in a healthy patient, and you are going to see the distinct things here. Peripheral ground glass consolidation and opacity that goes all the way up to the pleura. COVID-19 does not like the upper airways. It likes respiratory bronchioles, and alveoli. So you may see some peripheral round patches and patches that are all the way out at the pleura, a little bit like a Hampton's hump, but without the interlucency. Just notice how so many of these are touching the pleura. And this is the hallmark of the disease. You may also have some peripheral rounded ground glass opacities. We've gotten very good in our section at knowing the difference quickly. A lot of people are writing articles now about artificial intelligence and diagnosis. That's just people padding their curriculum vitae. Your radiologists will know when they see this diagnosis. All of them, I'm sure, have been reading the same articles that we've been reading, and you only have to see a few cases at your own institution to know. The most important thing I can say about the radiologic component of my talk, the takeaway point for all of you is, if the radiologist calls you and says that your patient has COVID as well as volume overload, believe them, okay? Believe them when they say it and act accordingly. Okay, now I'm gonna have to switch gears here and go back to some slides and talk about rapid prototyping and 3D fabrication. Can you all see my camera as well?
Yeah. Yes.
Okay.
Just please walk us through this process very swiftly. We are not at all familiar with this process, so please acknowledge our ignorance.
Right. Okay. So 3D printing and rapid fabrication has been around for many decades now, but it's only now come into common use. And, you know, classically, going back to historical times, there's always been fabrication and casting of materials and sculpture. The new process uses a variety of techniques to take computer data and lay it down layer by layer to create a sculpture. What people don't realize is it's not like an episode of Star Trek where you press a button and get something right away. There are many, many steps to the process. The other thing people don't realize is that 3D printers are not capable of industry level production. We're never going to get N95 masks mass generated from 3D printers. 3D printers are good for prototyping and perfecting designs on the fly, and also for creating individualized equipment, which is what we're doing in my laboratory right now, is making respirators that are specific to a certain physician. So for example, this here is a draft print of a mask that fits me specifically. That's a perfect seal. And as a consequence, the elastic bands are not going to have to be that tight. Here's another one, not off of its supports for Dr. Lau. These are all prototypes. Here's a prototype of a cartridge to take the N95 filtering material. So what are the steps? And I'll show some videos here in a moment. The first thing is you have to build files to create your designs. And this can be done in computer-aided design programs, CAD programs for engineering. And it can also be done by sampling from the real world, changing your scans to data, segmenting that data into meaningful shapes, and then switching those shapes to files that then can be perfected or repaired and printed. So I'll show you an example now of that. Oh, here, the actual scanning is going to be here. Amr, can you see this?
No, I still can't see your PowerPoint.
Okay, I just have to share the, there's just a little bit of switching back and forth that it has to occur here. Okay, can you all see a YouTube channel now?
Yeah, we can see whatever you're doing now.
Okay, so, nope. Just give me a second here. I'd encourage everyone watching to find our channel and join it, because there's going to be a lot of useful information. So here's Dr. Lau receiving his scan. Amr, can you see that?
Yes, I do.
So this is a structured light scan, and Eli Crane here is making an extremely accurate, down to a 0.5 millimeter scan of Dr. Lau's face. Now, let's move on and I'll show you what a what this looks like once it becomes a file. That's a blue image of my face from my scan becoming a file. So you have to have a data source. We can also scan with CT and reverse engineer materials. So here is a 3M respirator that I scanned to study its valve designs. This was done on a CT scanner. There are ways to use the medical scanners we all have to generate tremendous radiation to get very detailed scans of inanimate objects, and I cover that in another video. So once you have a scan, then you go into a volumetric visualization program like this one and separate the data that is of interest to you from data that is not. Then you export what's called an STL file, a stereolithography file, into other programs to perfect and smooth and plan supports for your print. And then ultimately the print comes from out of machines like this. This is, don't be offended, guys. Tariq Mohammed is from Alexandria. We take students in the, or research fellows in the lab from Mansoura as well.
Sorry, I forgot to tell the audience that you are helping a lot of Egyptian and international trainees and young investigators in your lab.
Right. We have tremendous respect for the Egyptian medical education system in America.
Especially Mansoura.
And Mansoura. Hossam El-Balassi is one of my former students, is up to be chief resident now in radiology here at University of Kentucky. And I would love to have a research fellow from Mansoura at Medical College of Georgia when I start in July. Unfortunately, I can't take Tariq with me. He's matched for his radiology residency at the University of Kentucky. So the prints come out of these printers here, then they go into a fixation bath of isopropyl alcohol, and then we incubate them in a heater that's just like a toaster oven. Tariq's just transferring a print from one to another. But the prints we make are not here, let me share back to the,
How expensive is this printer? Do you have any idea?
These are cheap, about $3,000. A university can get into printing at a very reasonable level. And this company we work with, Forms Lab, you know, they understand finances are different overseas than in America, and they would certainly work with all of you. Here is just some files that Sivash Tohidi, who's one of the artists here at the School of Art and Visual Studies, designed in a CAD program after extracting the seal from my face.
How many can you print per machine daily?
We have 6 printers, so we're printing 6 respirators. Here it says, hello?
Yes, we see you.
Did I lose my share here?
We can just see you. We don't see the screen.
Can you see the screen again?
Right.
Okay. So, we have 6 and these are very good printers. So we can do 6 a day. My colleague Ed Tackett in Louisville has 20 printers, and he could print as many as 400 a day. But that's not scalable. So my lab is good for rapid prototyping. Ed's lab can be a gap lab to supply a hospital for a few hours, but really we have to switch off once we get working prototypes to a local manufacturer. And the wonderful thing about these workflows is that we create is that then they can be commercialized fast in a general factory that has injection molding and a few other general tools. The other components of the workflow, which people all across America are missing, is that when you are starting to create new medical materials, you cannot skip biocompatibility testing and functional testing. We can skip the regulatory pathways through the government, and many of those are being waived. But you really cannot skip these things. If you're going to produce your own stuff, you must have labs that can test. Because if you don't, all you're delivering are false promises and feelings of security that are only going to make people less safe, not more. So one of the important roles I've been playing in Kentucky is slowing people down and connecting everyone doing fabrication to testing, which we have available here. So that may not be at your university in Mansoura, that may be in a lab, in a commercial lab, or it may be as far away as Cairo. It doesn't matter. You can't get a fabrication program going without that component. And then the last thing that has been a big problem for us that shouldn't be something you need to suffer through in Egypt because you have fair warning is that you need to reach up to the president of your university and to the regional government and then hopefully to the national government so that there is somebody organizing fabrication across the country, because otherwise it's too disjointed. So one of the things we've been successful in doing in the Commonwealth of Kentucky over the last week is we now have an infrastructure where we have a chief administrator for our governor, Andy Bashir, who is his name's Anthony Ellis, and so he top down gives us instructions. And then at the larger universities, we have chief administrators, and they then are delegating down. So there's a creation of an organization chart. Our local chief administrator was appointed by our executive vice president of health affairs, and his name is Jason McReynolds. And Jason called me today and said, "Can you be my sub-administrator for respirators?" I said, "No, for various reasons, just like you, Amr, I'm busy clinically." So between the two of us, we very quickly appointed somebody, Cam Henry, a former student of mine, who's already in that role at Vanderbilt. He's also going to do it for Kentucky because he can do it remotely. So now whenever anybody calls and says they want to make masks, or a hospital calls and says we need masks and we need them in a certain way and we need to order from local places, we have a person that acts as a conduit for all that information. Without that, without an administrative structure, as fancy as this all sounds, rapid prototyping, 3D printing, etc., it will fail. So we're only slowly coming to grips with that in the United States. In Egypt, create that first and then reach into your community to see who the people are who can do rapid prototyping and printing. And then you can work as one army, that's it in a nutshell. After we finish my respirators, we're going to hand off production of personalized respirators to Seiko Wave, a local company, and Toyota, the Japanese company that makes cars, etc. They have a factory here in Lexington, and they're going to step up and do it. And that's really the pattern this should follow. Questions? Oh, are we capable of taking questions?
Yeah, we'll take questions shortly. It's very nice. It's really very innovative.
Thank you, Dr. Amr. Dr. Amr.
Yes, I hear you, yeah.
Yeah, of course, on behalf of myself, my colleagues, I would like to thank you and Dr. Fabrizio, Dr. Javier, Dr. Michael for this nice presentation. Of course, sharing experience now is something essential, and realize the fact that we are a one community. For myself, I have certain questions, and we can accept now questions from the participant. I can ask for a support from our university for fabrication of personal protective equipment. We have a group of students from Faculty of Engineering working on 3D printing, but actually they don't have the medical experience about the filter we should use for mask like N95. And for myself and for my medical colleague, they don't have the experience for 3D printing. So if we can collaborate with Dr. Michael, we can ask the support of the president of university, and this can give the personal equipment we know we need now. We can ask the participant for question. I think Dr. Nisreen Omar, the dean of the faculty here, and I think she can ask questions. She is a professor of microbiology, and she shared the steering committee working group for COVID-19 in the university. Dr. Nisreen?
Yes, yeah, Mustafa, who are you? Yeah, one moment. Yes, yeah, Mustafa. Okay, can I ask now?
Yeah, of course, yes.
Okay. Yeah. What is the correlation between COVID-19 and the GIT? Because I found many cases with a presentation of vomiting and diarrhea, and even the stool it can be a sample for identification of the virus?
Dr. Fabrizio, I think you can answer this question.
Yes, so there is a recent study about that pointed about 50% of GI symptoms in patients with COVID-19. And indeed, it has been isolated in stools that the virus is not viable. So the fecal oral transmission seems to be not possible. And yes, it seems that many patients do present with either anorexia, nausea, or diarrhea in regards of GI symptoms. But again, it varies according to the series. The first series of the Chinese studies was about 10%. But lately there was a study, I'm aware, that had even 50% of cases had GI symptoms in isolation without any respiratory symptoms.
Can you detect the virus in the stool?
You can detect the virus in the stool, but it's not a viable virus.
Okay.
Okay.
Thank you. Thank you. Another question. You still have any news about the carrier for COVID? Asymptomatic person and transmission of the infection? Yeah.
I'm sorry, can you repeat the question?
Again, yeah. Any news again about the percent of the asymptomatic carrier and the spreading of infection?
Yes.
That's certainly a big area of interest. There have been some case studies, especially the German one, about asymptomatic transmission, but we certainly are not aware of the degree. I suspect that it's much higher than we think.
Okay, thank you. Thank you.
Thank you, Dr. Nasreen.
We have a question, Dr. Amr. Which is better, going for mass screening, okay, or selective screening for cases with symptom? Which is better?
Mass screen, the problem is it's very expensive to do mass screening. I think in the model in South Korea, they did mass screen, but it's very expensive. Here in America, even we cannot afford doing this. I don't know if you will be able to do mass screening.
Yeah. Another question. Do we have a solution for shortage in ventilators? 3D printing can help in this shortage?
Mike?
Yes. There are already robust plans that started at the University of California, San Diego, for splitters to use ventilators for up to 4 people. And those have now been perfected and disseminated. So you should be able to get those files, prototype them in Egypt, and then send them somewhere local to do injection molding of plastic. There are other ventilator parts specific to branded ventilators for which 3D parts have been fabricated. The most famous case of this is in Italy, where a company refused to deliver more and then threatened to sue a hospital for making their own. Just printing a part and using it without testing it is a last resort. But almost anything that you print with a known biocompatible resin, if it's simple, is probably going to work. So you just have to ensure that the media that's being used to print it is not something that's going to cause hypersensitivity pneumonitis, for example. So I have resins in my lab. For example, this draft resin you see here, this is breaking already because it's just draft resin. The dust from this, if you breathe it in, is an irritant. So the best resins are ones that are orthopedic devices. If you have those and fabricate missing parts for ventilators and dialysis machines and rely on them. If they're just a simple widget, a simple part that's missing.
But what about connecting more than one patient to the same ventilator? This carry a risk for secondary infection, dissemination of infection between patients?
It's a tremendous risk, but they're doing it in New York because they don't have enough ventilators.
Yeah. This will be the last resort.
Yes.
Yeah. What other line other than 3D printing for compensate the shortage of personal protective equipment? We have other options.
So yes, one of the things that we are doing, Ochsner Clinic in New Orleans has perfected patterns for sewing masks. If you can find material that is in storage somewhere that is appropriate. Now, surgical masks are different than respirators. They have a different rating system. An N95 respirator, whether it's permanent or throwaway, has a pore size of 300 microns. And it causes a 5-time reduction in the risk for COVID-19, which has a particle size of 120 microns, which admittedly is smaller than the N95. Regular surgical masks are not good for that. They only help with droplets and so on. But those surgical masks can be sewn. We have a sewing group here in Lexington. So as soon as we have materials tested, we're going to have people start sewing them. But there's another problem. The people doing the sewing may be contaminated. So we're working out a way for people to drop them off and then quarantine the masks. The most ideal thing is to find a local factory where they make anything, t-shirts, underwear, headbands, baseball caps, etc., and set a factory up to make face masks. So we have open access. A face mask is a garment, like a shirt. It has pleats, and you can make it wrong so that it's not effective. But those open access, open source files are available from the Ochsner Clinic.
Okay.
Very good.
I have also still I have a question. I am a general surgeon. How can I protect myself during surgery? Should I deal with any patient going to operative theater as a COVID positive and we're all personal protective, or this wasting of the resources?
If you're doing surgery on a confirmed COVID patient,
not confirmed patient.
Say, okay, so let's do 3 categories. Somebody with no symptoms who you don't suspect it, okay, versus somebody where you suspect it, versus somebody who is a confirmed case. Anybody who's sick, who has flu-like symptoms, you better wear a respirator. Because if you're someone like me, I'm 50, I have very bad hypertension, I'm obese, deconditioned, I could die if I get it. The pneumonias that we see as radiologists are terrifying. So absolutely, you need to protect yourself with somebody symptomatic. No question. Our thoracic surgeons are wearing respirators all day. That's why they're asking me to make customized personal respirators for them. In terms of asymptomatic patients, you're going to need to ask your epidemiologists at the hospital and also at the government level to assess the prevalence of the disease in the asymptomatic population. And then it's simply an equation of risk versus reward. You know, my personal opinion is that our surgeons really need to be protected first. So I have a list of people that we're going to fabricate stuff for once we get going, and it's all surgeons at the top, because they're the scarcest resource. But there will be people in the that work with you in the operating theater and in the clinics who disagree, who will feel that that's not fair.
Like you know, people will be at more risk for the infection rather than the surgical team.
Yeah. So, you know, the nephrologists will have a different perspective, of course. But I wouldn't, you know, a thoracic surgeon takes, what does it take to create a thoracic surgeon? 20 years? You know, radiologist only takes 5, nephrologist 5. So I'm putting myself in the same category with you.
Okay.
It's just, you know.
I have a question from my friend Khaled. He asking why there is a rapid increase in COVID-19 cases in USA last days.
Because people in the United States culturally are self-interested. We have people who went to Florida for spring break and then spread back to every college in the country. People in New York, it's like people in the Middle Ages fleeing cities with the plague out into the countryside. If you look at our cell phone data from New York over the last few days, and we can track, you know, cell phones, every people from New York have gone in droves to every single state in the United States, including Hawaii and Alaska, which aren't even contiguous, and Puerto Rico, which is an island. So the New Yorkers have super spread it all over the country because they themselves think that they can flee somehow from a virus. And
Mike,
this
do
is,
you think it could be also related to the wide availability of testing? So we are testing more people, so we are anticipating more positive results?
no, I think that we're testing, I mean, I don't know, I just know what I read in the news, but we're testing whatever, 3 times as many patients, but it's accelerating, you know, there are 10 times more cases per day. It doesn't add up.
So here we tested just at UK, at University of Kentucky, more than 1,200 patients, and only 35 were positive. Among from the 35, 32 were just, you know, walkie-talkie outpatient, you know, not sick patient. So
This is the way it needs to be done, because our epidemiologists and public health people can track every single one of those patients backward through all their contacts. Kentucky's doing a great job. Tennessee, it's skyrocketing. So it depends on culture and leadership. We have good leaders. I mean, look at Georgia. It's going insane because their governor wouldn't shut things down.
I agree. What do you think, Fabrizio?
Yeah, I agree with Mike. So there's a difference in which states have taken public health measures to try to kind of decrease the famous curve and do mitigation measures. Certain states, when they tried to do these changes, it was too late, like New York. So there is a component of that the wave is just kicking, and also a lot of testing. But I certainly believe that there's more testing still to be done. And the best strategy, if the economy allows it, is to do widespread testing like South Korea has done.
That's absolutely the most important thing.
Agreed. So,
we need to know who's recovered so they can go back to work too.
So Mustafa, do you have any more questions?
Last question. What about herd immunity, which is postulated by UK? Is there still a chance to use this theory in any country?
I think they walk, you know, far from this. and the professionals, they said, no, they cannot compromise on their own people and just let the infection spread out, because this can cause a fatality of more than 600,000 only in England if they allow this to happen. So I don't think it's valid anymore. What do you think, Mike and Fabrizio?
Yeah, the whole thing is, if we don't do any mitigation strategies, we're gonna get a super fast surge of new cases, and any hospital system cannot tolerate it. You're seeing in New York, that is one of the most advanced cities, they cannot tolerate the increased amount of cases. So you have to do some strategies to try to decrease the spread of the virus. And the other thing about the herd immunity is the virus is already having some mutations. So that's something worrisome. And again, we are just learning about this virus day by day.
I agree. And also, you don't know if this will give you lifelong immunity. It's a very new virus, and whatever we ignore about this virus is much more than whatever we know. So I don't think anybody can compromise on his own people and let them get infected and develop immunity. Do you agree, Mike?
I only know what I know from the news, because I'm not that type of doctor. Remember, I sit in a room and look at pictures all day. Ask me to balance acid base, It's not going to happen.
Understand, but you are very innovative. We know that we know the basics more, but you are up to date with the new changes in your field. I really appreciate that. Dr. Mustafa, Dr. Nisreen, and all the audience, thank you so much for allowing us to have this nice webinar. I think personally, I learned a lot from this, and I really appreciate Mike, Javier, and Fabrizio sharing, and also Soliman sharing with us their experience and their information. Thank you, everybody.
I enjoyed it, everyone. Thank you.
Thank you.
Thank
We
you.
love Mansoura. Go Mansoura.
Thank you.
you.
Thank you. I will end now.